Thank you, everyone, for joining. I did ask if you would sign your name and organization on the chat line. Welcome for a change. It's the southern part of the North Country that has gotten dumped on, and I guess the northern part isn't doing so bad right now. But I hope everyone's safe. Claudia, can you advance the slide, please? We're going to spend a little bit of time today talking about PCMH, the 2021 criteria, QPAS, and then the updated tracker grid. I'm going to turn this part over to Jessica. She was kind enough to put some slides together and also update our tracker grid. Hopefully it'll be a little bit more user-friendly and helpful for people. As many of you have just completed your submission for 2020, if you will, I think almost everybody that we reached to or needed something has gotten through it all. So again, if you're still looking for some assistance, please don't hesitate to reach out to us. So without further ado, I will turn over to Jessica. If you'd like to lead us through these slides, that'd be great.
Thank you, Luann. Good morning, everybody. Happy Thursday and happy snow day to many of us. So this year is more or less wrapped up for most practices. Anyone due to submit this year, for the most part, has. I know of a couple of sites that had some extenuating circumstances and did get a submission deadline through the 31st. But at this point, I think everybody is going to be looking towards the 2021 standards. We've talked about it a little bit in the past. There aren't a ton of changes between the 2020 annual reporting guidelines and the 2021 guidelines, but there are some differences and some nuances. So most of the changes are reflected in the fact that NCQA has responded to the COVID-19 pandemic by allowing a lot of these standards to be met via telehealth. So they worked in a little bit of flexibility. If you did change any of the way that you conduct your same-day appointments or some of your access measures, or even some of your care planning, you'll want to go back and just update your policies as you're going through and reviewing everything to make sure that you include the process for telehealth. One of the important ones with that is also your patient materials. If you give out new patient materials and telehealth is now a permanent part of what you're doing and how you're offering access, you may want to call that out either on your website or in your brochure, or in any way to let patients know that this is an option. They can call for a telehealth appointment. So anyone who has a reporting date now in 2021 should be looking at those 2021 annual reporting standards. There is, the whole publication is on NCQA. We've provided that link before, but if you need that, let me know. We do always suggest that everybody just get those documents. There's some important information in there, not only the criteria that you're going to report on, but actually the QI worksheet that you're going to use for 2021. And it is different in 2021 than it was this year. So there are some changes. Stays mostly the same, but they do want some additional information, like they want to know what guideline source you're using for some of your measures. And they called out a specific line in the QI worksheet for start date for your actions to improve. So go in, if you haven't downloaded that already, take a look at that. And again, feel free to reach out with any questions. We can move to the next one. And I just wanted to remind everybody, so if you got the extension this year, meaning you were due to submit sometime between March and September, but NCQA granted you the extension and you were able to submit later this year, and perhaps you submitted in December. If your original reporting date this year was on the earlier side, you know, if it was March or April, you're going to have to submit again relatively soon, because NCQA did not make this a permanent new anniversary date for you. You will retain, as of right now, again, because the pandemic is ongoing, they may change this. But as of right now, whatever your reporting month was for 2020, originally, that's what you're going to, when you're going to report in 2021. So you most likely won't have that full 11 or 12 months after submission to report again. So remember, when you're coming up with your evidence reminders, that your evidence should be from within the past 12 months, but it also has to be new data from after your last submission. So, you know, the QI worksheet data that you just submitted might still be fresh within 12 months by the time you're due to submit next, but you can't reuse that data with those same reporting dates. You're going to want new data to show a new QI process for 2021. Always make sure that you redact your evidence for PHI if you're uploading things like screenshots or reports. And just always follow the rules for site-specific or shared if you are a multi-site. Next. All right, so the tracker. We've gotten some questions this year, quite a bit actually, for practices who are in annual reporting to say, you know, I'm going through everything, I'm looking at all my criteria, I'm not exactly sure what I should be saving for my audit files and what I need to do in QPAS. You know, what's going on with QPAS this year, because it doesn't look like there's a lot that I have to do, but I want to make sure that I'm doing everything right. So what we did, and Claudia, if you want to go to the next slide, we added a new column. So after where we indicated what type of evidence you need, whether it's a documented process or a report, we added another column to say, well, what do you do with it now? So if you're a transforming process, for instance, for TCO1, you're going to create this document that details information about your clinician lead and your PCMH manager. You're going to actually upload that to QPAS, or you're going to share it during a virtual report review. If you are an annual reporting site, take a look at it, make sure it's up to date, change it. You know, if your clinician lead changed or your PCMH manager changed, you would want to update that document, and you're going to save that with your audit files. There's no question in QPAS about this, and there's nothing that you need to upload, but you still want to do that review and just save it with audit files. Just remember that there are some criteria like New York State criteria. If you've already gone through them, you're going to see those show up as being awarded as transfer credit. Most of them. There are two New York State criteria that you're always going to have to submit. The first is CC21A, and the other one is QI19. So they always want to see each year evidence that you're still connected to a qualified entity like HCME or Healthy Connections, and that you still have a value-based payment agreement in place. Next. All right, so just a couple more examples. With annual reporting, it really differs depending on the criteria. So you can see here that there's lots of different things that you might have to do with your documentation. You might have to review it, update it, save it in your audit files, and then just answer some quick questions in QPAS. You might have to actually upload a QI worksheet in QPAS, and you might have to run a report, answer some questions, and then enter the numbers from the report, but you keep your report for your own audit purposes. So varying degrees of what you will be required to do in annual reporting, but hopefully this column will kind of outline exactly what you need to do with your evidence and what you need to do in QPAS. Next. All right, so speaking of QPAS, we've gotten a lot of questions about QPAS, and we've had a lot of questions about QPAS because, quite frankly, we've seen just a lot of updates this year. And when an update occurs, sometimes it changes the documentation that's in there. Most notably this year, we saw some issues with criteria being marked as met and locked before a practice had actually submitted for it. And this was different than just having things awarded by transfer credit. This was for criteria that practices were actually expected to upload something, but couldn't because the criteria was locked in QPAS. So that can get confusing sometimes, especially if you're not familiar with QPAS to begin with, to know, what's a glitch, what's something that's new with an update, and, what's something that I just need to figure out how to work because it's the way that it's supposed to be. I just need to know how to function within QPAS. So we wanted to make sure that everybody was aware of some of the resources that are out there with QPAS. So the most recent webinar that they have available on their site is called What's New with the Q. It's a free webinar. It is about an hour and a half. And some upgrades have been made to the system since the webinar was first developed, but most of the functionality remains the same. So if you have an hour and a half of free time, it can be very helpful just to get a familiarity with the system. There's also the Ask a Question feature within QPass. So if you're having some technical problems or you think something might be wrong with the system itself or with the way your sites are set up, you can always ask a question right through QPass and just indicate that when you do the drop-down categories that it is a technical question. QPass also has some Q&A sessions. They're held periodically via Zoom when there are updates to the system. So if you go to that link at the bottom, that's where they have all of their education and training webinars. There's some great resources on there. Some are free, some are paid, but they have some good options there. And those Q&A sessions are great. When an update comes out and they hold those, you come prepared with some of the questions that you have and a basic familiarity with the system. And you can ask questions about new functionality or about something that you've noticed that you're not really sure about. Or you can just sit back and put yourself on mute and listen to other people ask the questions, which is what I typically do. But it's a nice feature to have, especially if there's something new coming out and you don't want to play around with it. You want to hear somebody explain it first. So I think that's all I have for everybody today. So I'm going to turn it back over to Luann to introduce Ruth Ann, and I hope everybody stays safe in the snow.
Luann, you're on mute.
You just missed the best statement ever. Could you go back to the tracker, and I just open up for questions at this point in time, because I know many people did have some struggles with the tracker grid or with the QPass, and we thought maybe the tracker might be a helpful item if we included that information. Anyone with questions or comments about any of this information? Thank you, Sandy. I appreciate that. Yeah, we are hoping that this column, we put the new column in. Can you go back a couple more just to show that what to do with the documented process and evidence? And, you know, as we were helping people through the process this year, you know, it was very clear that it's confusing, and it is. QPass is not necessarily user-friendly. I guess the good news is they do change and make updates, but the bad news is it's still confusing. So they're definitely a work in progress. The one thing I would love to stress to you all is if you could find some opportunity to get this tracker and fill it out now. We're going to distribute it right after the meeting today. And we'll send everybody a copy of the tracker so you can, and it's not locked or anything. It's, you know, open to your utilization. So I know some people have said they kind of do a little bit of different thing, but, you know, if this works, great. And if not, at least you can, you know, cut and paste, take what you need. But I highly recommend people, now that you've just been through the recognition process, to fill this out right now, while you still have all that information fresh in your mind and fresh where you kept it. So then as you proceed over the next months, you'll have this already there for you, and hopefully it won't be as painful going through it this coming year. At this point in time, you know, again, what they're telling everyone is that your regular annual renewal anniversary date is the one you have to look towards to do your next recognition. So there's no extensions at this point in time. And we don't really anticipate extensions. Hopefully people have gotten enough of their new life sort of ironed out, if you will, unless something really goes sideways again. I would suspect they're just going to go with the usual anniversary dates. So again, I will stress it 100 times over. Get this filled out now, make your lives easier. And then every month, you know, take a look and figure out which pieces you need to be working on. It could be as simple as an hour or so a month just to put your eyes on this and say, should I be doing anything different? Am I still tracking okay? Even to spot check some of those QI work efforts you've been doing on to see, working on to see if you're moving forward. You know, it is certainly something I know many of you do in various ways, but again, just to open this up once a month and say, are we okay right now?
Luann, I have a question.
Sure.
Angie at Aliside.
Yeah, hi, Angie.
So our regular renewal date before the extension was August. So meaning we had to submit by the end of July. So if that remains the same, then all these measures, since we submitted in December, like all our QI work has to actually happen between January and July, right? To submit?
Correct.
Okay. I don't know that, but
that's why I'm kind of like prompting people to think about it now, because that's exactly right, Angie. You can't use anything you just used. You're only going to get a short runway of when you can actually submit data. So if you're not paying attention to say, do I have enough numbers? Do I have enough, you know, examples? Do I have enough patients that I can really provide that QI information?
okay.
But yeah, that is the case. And I know there's a few of you out there that are actually due like in May. So again, you've only got, and so that means you have to submit in April. You've only got about 3 months. And, you know, people still aren't up to their same level of numbers of visits. And so it becomes challenging to say, do I have enough to submit this? So I just remind people to kind of take a peek month by month and see how you're doing. Great question, Angela. Thanks. Anybody else with questions or comments? Okay, so we're going to go ahead and send this out after the meeting along with the PowerPoint. We put the recording up on the website, and we put the PowerPoints up now too. I think what we could do too is even put this up. I'll work with our internal resources and see if we can't go ahead and put it out there in case you don't get to it right away. You have the reference, whatever. And then if you have any comments specifically as you're using this that says, be helpful if we could do this, that, or the other thing, you know, feel free to share, because I think everybody can, you know, use a trick or two to help manage this work that could be Herculean, but, you know, it could also be something managed every month if you just try to stay ahead of it, which I know is a ridiculous statement, but I thought I'd say it.
Luann and Jess, this is Janet. I have a quick question.
Sure.
So QPAS actually says that Aliside's next reporting date is November 11th of 2021. Are you guys saying that's not correct?
Interesting. So the practices that I've seen that have gotten recognition, they did revert back to their original anniversary date. We can look into that one though.
Yeah, and any of the practices, I just sent you an email, Jess, any of the practices that we submitted at the end of November, they're sending emails saying that they'll have new recognition dates. So,
oh my goodness.
Oh.
Yeah, I sent you an example, Jessica. So I'm just curious if they're sending those, but they're in fact not true. They shouldn't be sending them.
Well, because they've been pretty adamant about whenever we're talking to any one of them that no, just remember your anniversary date is your original. I mean, numerous times they've said that and or shared that information. So that is a bit of a surprise. We will do a follow-up, and we will make sure we get that information back to you as soon as possible, if not by the January meeting.
Okay, thank you guys.
We'll try to get it as soon as possible. Yeah, others are saying that their anniversary date's been revised to November. That's interesting. I wonder if it's a system glitch, because that's what the system does. It automatically gives you another, you know, year. Okay, we'll follow up. So the other you know, we keep evaluating, Brendan, myself, and others, evaluating this meeting. Is it helpful? What could we do differently to make it a little bit more pertinent and help those that are really trying to do the, you know, work on the ground, if you will. And so Ruth Ann Craven from Hixney has been gracious enough to agree to be kind of a standing agenda item or a permanent member of our group as much as she can with her time constraints. So we will have that Hixney resource readily available. So to keep in the back of your mind every month, if you've got questions specific for Hixney, you can send them ahead of time. You know, we can get them on so everybody can learn what the struggles are. Certainly don't wait to get a result or an answer to your question, but at least send your questions forward, and we'll make sure, you know, we can get that information out to everyone so they can maybe benefit from that. So today, Ruth Ann is joining us, and she's going to be talking about improving the quality scores and a little bit around the EHR documentation. So good morning, Ruth Ann.
Good morning. Thank you for inviting me to join your meeting this morning. Next slide, please. So what I'd like to talk about today are some of the lessons learned from Hixney's recent NCQA validation for health plans to use our data for HEDIS reporting. Although I met with some of you individually to review your results, I thought it would be a good idea to kind of share an overall picture of all the feedback we got for all of Hixney's data contributors. So next slide. So as you may recall, we were validated in October, and 118 of our data sources passed without any condition. We had 102 pass with omission, 8 pass with a minor error, 14 were not approved. There were 31 we couldn't submit for various reasons. It could be that the practice or provider refused to participate, or they were a community-based organization or a care management organization that the auditors felt didn't have enough clinical data. And then since our validation, we've had 25 new integrations. So we are working with all of the data sources that did not pass unconditionally to try to improve the documentation to make sure that next year when we're revalidated, as many data sources as possible can achieve that pass score. And the next validation is targeted for next summer, so around the June or July timeframe of 2021. So next slide, please. In order to be validated for NCQA, an organization must be a data contributor. So that means you're connected to Hixney and sending data to Hixney. We also have participants who access Hixney data on our portal, but are not contributing data. So obviously we can only validate the organizations who give us data to be validated. And the second thing to think about is the format that your continuity of care document is in. NCQA prefers that the most recent version of the CCD in the clinical document architecture is version R2.1. We had a number of eClinicalWorks practices that were validated, but they passed with omission because they were on version 1.1 at the time they were validated. But eClinicalWorks has since upgraded all of their clients to R2.1. And we've done another mock primary source verification to confirm that we are now getting all the data from eClinicalWorks. So if they were validated today, they would have passed unconditionally. We have some athenahealth clients who are still on version 1.1. There was a mix of those. They passed, but a lot of them passed with omission. And then we have a handful of data contributors who are on the old C32 format, which we could not validate them at all. So we're working with them to get them upgraded to a more recent version of the continuity of care document. So next slide, please. At a very basic level, there's two main things that we need in order to make sure that the data comes to Hixney. First is the use of structured data fields. So these are discrete data elements that can be reported on in your EHR, not free text fields. And the second is standard coding. So standard codes are things like ICD-10 or SNOMED codes for diagnoses, LOINC codes for lab results and vital signs, and CPT or HCPCS codes for procedures. Some organizations use their own coding system, which is referred to as local codes, but the data associated with local codes does not always come to HCSCN if we don't have a crosswalk to one of these standard coding systems. So next slide, please. When primary source verification was completed by NCQA, there are a number of data that they were looking at, and it was mostly focused on clinical data that applies to HEDIS quality measures. So it's the things on the screen that you see, basic demographic information, procedure codes, diagnoses codes, admit and discharge date if applicable, immunization codes and descriptions, lab results, vital signs. And they also looked at additional data like smoking status, social history, allergies, and medications if they were mentioned in the progress note that we received. So pretty much anything in the progress note is fair game for the NCQA auditor to look at. So now let's go into a little bit detail of each data type and what the kind of errors or omissions we saw. So on the next slide, please. Next slide, sorry, got ahead of myself. Okay, so by far the largest area for errors or omissions or reasons why data sources could not be validated related to lab result information. So just a reminder that LOINC codes, which are logical observation identifiers, names and codes, which is a universal set of different codes for laboratory tests, should be used for any lab results. We did have a problem with some MEDENT. Some of the MEDENT lab results are being reported as laboratory test code finding, which is not specific enough. We need those LOINC codes so we know if it's an A1C or a white blood count or a lipid test. We need a little more detail. And in general terms, when you're providing medical record documentation for primary source verification, you always need to include the lab results if labs were discussed with the patient on the date of service. The best place for that is having them embedded in the progress note. If they're not in the progress note, you should send screenshots from your EHR. We had several organizations who get their lab results electronically from hospitals, and they submitted a CCD for that documentation, and the NCQA auditor would not accept a CCD as medical record documentation. Next slide, please. So the second biggest area for omissions were vital signs. Again, LOINC codes should be used for vital signs. Some EHRs like GE Centricity was using local codes, but you have since corrected that and you are now having those vitals coded with LOINC codes. So thank you for that. And the other thing, if you had an omission with vitals, is kind of thinking about how do they get documented? So for example, if a nurse is rooming the patient and recording the vitals, where are they recording that? And how does that information get to the CCD? So for example, with MEDENT, some practices have the nurse or the MA document the vitals in a nurse note. But that nurse note will need to be pulled into the progress note in order to get that information to the CCD. Another thing, when you're providing medical record documentation for primary source verification, be sure to provide documentation for all the vital signs for the date of encounter. For a physician practice, it's not that big of an issue. The only thing I can think of is if you recheck the blood pressure, make sure that both of those blood pressure readings are coming to HCSCN. It was a big omission for hospitals and skilled nursing facilities because they take vital signs so many times for a patient, and they didn't always send each instance of the vital sign that was requested. Okay, so the next slide, please. Okay, another important area for improvement are diagnoses. Standard coding, so ICD-10 or SNOMED codes should be used for diagnoses. Diagnoses must be included in the CCD as either an encounter diagnosis or a problem. For MedEnt, if you have assessments, if you're working with assessments in your system, you need to add those to your problem list in order for them to come through to HCSCN. Whenever there's an acute condition, the acute condition should be marked as resolved at a subsequent visit. So say, for example, I see my doctor for a UTI. The next time I go to my doctor, hopefully my UTI is cleared up, so that should be marked as resolved. And then in HCSCN, that would move from a present illness to a past illness. That's important because the auditors are looking at acute versus chronic conditions. And we did have an instance where a UTI was not marked as resolved. So it looked like the patient had a UTI for 3 years, but they had a UTI 3 years ago, and then they had a UTI again this year. Yep, go ahead.
I'm sorry, this is Angie Alice Hyde. I just went back up a little bit. When you say MedEnt assessments should be added to the problem list, are you talking about like depression screening assessments, substance use assessments, or something different?
No, I'm talking about some doctors document their diagnoses as assessments. And so it's pulled into the assessment section of a progress note. And they should always be adding those assessments to the problem list. And they don't always do that. And if they didn't do that, that was an omission.
So selecting a diagnosis code, but not adding it to the problem list?
Correct. Yep.
Okay. All right.
Okay. Another thing to keep in mind is any diagnosis on your CCD must also appear on the progress note that you provide as medical record documentation. This was a problem also with MedEnt for practices that code their diagnoses from their billing system. You have to make sure your billing system is synced up with your progress note. And looking ahead, we have a very important focus for 2021. HCSCN is looking to get more data on social determinants of health. And we would like to encourage everyone to start using the ICD-10 Z codes to code those social determinants of health. So there's codes like Z59 is homelessness, Z59.4 is lack of food and safe drinking water. We did find out last week there may be incentive for physicians to do this. There's going to be a change in E&M reimbursement. So your evaluation and management reimbursement can be coded at a higher level if you also document social determinants of health for that visit beginning in January. So definitely if you're coding Z codes, be sure to include them on your CCD that comes to HCSCN. So next slide, please. Okay, procedures. We had a couple of omissions with procedures. First of all, they should be coded with CPT or HCPCS codes. In a physician office, the omission was usually if it was a well visit and the patient had a urine dip done. The urine dip was, normal, so nobody did anything with it, but it was mentioned in the progress note. So if it's mentioned in the progress note, you do need to code that CPT code, which I think is like 81,000 for a urinalysis, just to make sure that the two are synced up. And this gets to Angie's question. So you might also consider documenting your psychosocial screenings, like your depression screening, with a level 2 CPT code, because then that information can be parsed by HCSCN and appear in the portal under the procedures section. And I have some links to some basic coding tips for integrated behavioral health care, as well as a very extensive list of codes from one of CDPHP's documents, which is the 2020 effectiveness tool for providers. Okay, so next slide, please. Smoking status. Not a lot of problems with this for physician offices, but Point Click Care, which is an EHR used by nursing homes, has what's called a feature where they allow skilled nursing facilities to default smoking status to unknown. You should never default any values in your EHR because you can't provide documentation that you actually ask the question when it's unknown. Another thing that we saw occasionally was the status was updated in the EHR. So when the CCD came through, maybe the smoking status was dated December 17th, but the progress note didn't mention that they asked the patient about smoking status. So we didn't have that documentation to support that. And a problem we've seen recently with MedEnt, somehow some of our data contributors are able to document multiple smoking statuses for a patient at the same time. So a patient looks like they have they're a current smoker, a former smoker, and a never smoker all at the same time. We have resolved those issues with MedEnt for those data contributors. But if you do notice the ability in your system to mark multiple smoking statuses, that's a problem, and you should look into that. Okay, so next slide, please. Okay, so now I'd like to talk a little bit about the medical record documentation. So a couple of tips about the actual progress notes that you provide. So next slide. Okay, one thing we saw in very many cases, the practice name and the address is not on the progress note. You should always make sure that's on your progress note. And the provider who e-signs the progress note needs to match the provider who saw the patient and needs to match the provider or author on the header of your CCD. That happened in cases where maybe a nurse practitioner or a physician assistant saw the patient and they actually had their supervising physician sign the progress note. That type of situation, there needs to be more of a flow. The e-signature needs to actually match who is the official provider of care for that visit. Another thing we noticed with some MedEnt family accounts, just make sure you're doing extra care when you're documenting with a family account, that you're using the correct medical record for the patient you're actually seeing. So for example, it's common for pediatric practices to do group visits with all the children in the family in one room. So just make sure you're picking the right child's account when you're documenting that visit. And to Jessica's point, telehealth really exploded with the COVID pandemic. And telehealth is new to a lot of practices, and it also was very new to the NCQA auditors. They rejected a lot of organizations' records because they didn't feel they were robust enough. So a couple of tips on that. First of all, telehealth visits require both audio and visual. A telephone call does not qualify as a telehealth visit. If vital signs are reported by the patient during a telehealth visit, your progress note has to indicate that they were self-reported by the patient. It was surprising, but the auditors were questioning why height and weight were on a telehealth visit, and it kind of makes sense to me that the patient reported that information, but it didn't say that in the progress note. And the last thing for telehealth, if the telehealth visit is for a prescription renewal, first of all, there needs to be documentation in your EHR. I had a provider send me a handwritten medication reconciliation on a while you were out pink pad. That does not work. And secondly, any prescription renewal needs to have an appropriate diagnosis. So for example, if the renewal is for lipids, we would think that, for statins, we would think that the diagnosis would be hyperlipidemia. You can't use a well visit diagnosis for a prescription. If you're giving a medication, there needs to be a diagnosis related to that medication. Okay, so next slide, please. So that wraps up our lessons learned from NCQA validation. So do we have any questions about that, what we've covered so far? Okay, hearing none. So we'll move on to the second part of our conversation today, which is on care plans. We received many questions about how to share care plans with the Health Information Network, particularly from primary care practices who are looking to do that for NCQA recognition. So the next slide, please. So let's start with understanding how physician practices send data to HCSCN. So there's two ways. First is the continuity of care document, which is a core data set of the most relevant information to support continuity of care. It's provided in a standard HL7 clinical document architecture format. These are the same documents that you would send to a specialist whenever you refer a patient for a consult. Continuity of care documents include both structured data, which is coded, and then it also includes free text or HTML information. The other way that practices send data to HCSCN is in unstructured documents. So things like your progress notes, nurse notes, clinical visit summaries, care plans. Okay, so next slide, please. So when HCSCN receives data, so a CCD comes into HCSCN that includes both structured and non-structured information. All of the structured data from the CCD is parsed into the various tabs of the provider portal. So the problems, the diagnoses, the medications, the lab results. Or that parsed data can be integrated into your practice EHR, depending on how your interface is set up. Care plans are unstructured, and they're only available as documents, either within that CCD or as a separate unstructured document. So next slide, please. So this is an example of a patient. You can see we're on the documents page for the patient, and starting at the bottom of where I circled. There's a continuity of care document, there's a nurse note, and there's an emergency department report, which is the physician's note. So there's a large selection of different types of documents you can find for a patient within that documents tab. So if we go to the next slide, we'll talk a little bit about the things you should check. There's two things to check in your EHR system, or you can contact your EHR vendor if you do not know how to do this. So the first thing is when you're creating your continuity of care document, you probably have a template that you need to update. So on the left, you'll see a screenshot from Greenway. This is Greenway's CCD template preferences. And you can check off what sections you want to pull into your CCD that is sent out. So you make sure that you check off your functional status, your goals, and your health concerns, and that will make sure that all the things that are typical to a care plan will be included in your CCD. So the other thing you need to do is set your preferences about how you're going to document your care plans. So on the right, this is a screenshot from MedEnt on how to set up care plan packages, which a lot of times people say, well, these are really for the doctors. But actually, if you think about it, you know, it has goals and it has instructions and it has other information. You can create care plan packages for your care managers to use. Then the next slide, please. Okay, so then I wanted to show you a few examples. So this first example is from NetSmart, and this is an example of how the care plan appears in the CCD. So it's goals, it's interventions, and it's completed interventions, and that section is just kind of enlarged. It would be actually underneath the intervention status section. So it has all of those and it has the date. So you can really see clearly what's going on with the patient and what the most recent intervention has been. The next slide, please. And so physician progress notes can include some care plan information. So on the left is an example from MedEnt. You can see I circled where all the care plan sections are. So it can be set up so for each diagnosis that is assessed, you can put that care plan or pull that care plan into the progress note. In this case, the practice didn't use care plans, so it's blank. But that is a place where you can have your care plan information pulled into the physician progress note. On the right is an example from Point Click Care. With Point Click Care, you add the care plan component to chart notes, and then it is pulled into the progress note. And when it's pulled into the progress note, it can be updated, printed, or you can mark the interventions as they're complete. So next slide, please. So this is an example of a nurse note, which I put together using like a MEDENT template, which is something that maybe a care manager could do. If you want your care managers documenting care plans in nurse notes, they can do that. And nurse notes can be sent to HCSCN just like the progress notes are sent. In order to do that, you just need to let MEDENT know what the name is of the template that you want to be sent to HCSCN. So when your integration was set up, you told MEDENT what templates you want to be sent to HCSCN. So if you're adding nurse notes, you just let them know what the new template name is, and they will make sure that they be sent to HCSCN as well. Okay. And each EHR system is unique, so we encourage you to work with your EHR vendor to learn how to set your preferences and create your templates for care plans. So what questions do you have about care plans?
Ruth Ann, this is Luann. So they document it here, but then they have to work with their vendor to actually get it to become part of the CCD?
Nope. If we go back to, go back a couple slides. Another one. Okay. So every EHR system will have a screen like you see on the left here. And every practice should be able to create their CCD. And they select their preferences of what they want to include on that CCD.
Got it. And that's where the care plan shows up.
Yep. And then the care plan, if you go to the next slide, would look like,
that. Okay.
So this is how it looks in NetSmart.
Right, but I'm wondering, what do you have a slide here? Because I don't remember seeing a slide. What does it look like in HCSCN?
It will look like this in HCSCN. You'll go to the Documents tab, you'll open up the CCD, and this is what it will look like.
Okay.
Or if you're sending the progress note, it will look like the actual progress note. Right. So the next slide, the examples that I showed you.
I think it's just challenging that everyone looks so different, so you never know where to be looking. That's what I find difficult when I go in there. Like, where am I looking for this? Because is it in the progress note? Is it in the CCD? Or is it in this, you know, a separate example here? Is there ever a thought that they would pull that into just an area called care plan?
We can't at this point because it's not structured data. It's not coded.
Okay, thank you.
And I had this conversation yesterday with actually a home care agency, and they're like, well, how do people know to look at documents? Yeah. So that brings me back to the work we're doing on social determinants of health. So we're trying to get more information about a patient's social determinants, and we do plan on adding that information to the patient record snapshot, where currently we show the quality indicators and the COVID reporting. We're going to add a third toggle to that for social determinants. So if I'm going into the portal to look at a patient, I'll see that they have social determinants, and then that should prompt me to, oh, I need to look in the Documents tab. I need to look for that care plan to kind of see how that is being addressed. So it's clunky, you know, it's not that straightforward, but it is progress. Mm-hmm. And I saw a quick note, I kind of missed the details there, but Sandy, you were asking about Athena? Okay. Let me open chat. Okay, so Athena has been nearly impossible to work with regarding CCD. If there are any practices using Athena, can you contact me? Okay, and I will certainly pass that along as well, Sandy, as I'm working with Athena practices. And Lisa, we document our goals in our progress note and use the visit summary as our care plan. eClinicalWorks told us They will not send the progress note to Hixney. Oh. Okay. All right. Any other questions? All right. Well, thank you very much, everybody. And, you know, if you have any questions before the next meeting, feel free to send me an email.
Luann, you're on mute again.
Thank you, Brenda. This is why I leave my video on in case I'm talking, someone recognizes it. Okay. So we're, you know, trying to plan out for 2021 and topics that we will address. So I really encourage you, if there's a topic you think that would be of interest to you, or for that matter, others as well, that you send us, you know, an email or just let us know and we can add it to the list. We did know risk coding is something we're going to be talking about. And I don't know, Brenda, if you want to chat for a few minutes about some topic thoughts we've discussed.
You know, I think there's a lot of different things that are happening, you know, certainly across the region. Really want the feedback, you know, from the providers who are on the phone, of things that you would like to hear from us. I think as we move along with our different work groups, you know, our quality improvement work groups, our pediatric work group, care model. There may be things that you're hearing if you're participating in any of those work groups, that you bring that, you know, here, and different topics that you may want to hear on. I think, you know, as we move forward, the assistance with PCMH and, you know, bringing some of your questions here, that's certainly something that, you know, would be considered monthly. But I think as we move forward, you know, how can we support the efforts that you have, you know, that you're trying to fulfill your NCQA requirements, but also looking at ways to improve our quality. And, you know, Ruth Ann, thank you. I mean, that was really helpful for me to really understand how things are being sent, and for us to be able to support practices as well, to be able to get this documentation over. We know that care plans are being developed, but we can't see them. So how can we certainly put those out there that can, you know, those can be shared, so.
Well,
Okay. Anyone with topic ideas that they think we should add? Okay, well, if you think of something, please don't hesitate. It is at the top of the hour. Unless anyone else has another question or, you know, thoughts, we'll go ahead and end the meeting today. Everyone have a great holiday. Stay well, stay safe, and hopefully you'll at least get to see your family in some way, shape, or form. I'm sure Zoom will be quite busy over the holidays.
All right, thank you, everybody.
Thanks, everyone.
Thank you.
thank you. Take care.
Thank you.